Good afternoon, everyone. Welcome to the featured clinical research part 2 session. My name is Samir Pancholi. I'm an interventional cardiologist from northeastern Pennsylvania. Our first presentation is by Dr. Samir Khandhar, and it's about long-term outcomes following mechanical thrombectomy for high-risk PE. Dr. Khandhar comes to us from University of Pennsylvania.
All right, thank you very much. It's my honor to be able to present the long-term outcomes following mechanical thrombectomy for intermediate and high-risk pulmonary embolism patients. This is the 6-month FLASH registry results. Disclosures, I am a consultant for Inari Medical. Pulmonary embolism, as we know, is associated with both short and long-term morbidity and mortality. Unfortunately, long-term effects after their index PE event can include ongoing symptoms, decreased exercise capacity, and impact their quality of life. Catheter-based treatment options, such as large bore mechanical thrombectomy, have been shown to have promise for short-term safety and effectiveness outcomes. However, longer-term outcomes and their impact on a patient's quality of life, physical ability, and symptoms has not been well studied. The 6-month results from the U.S. cohort of the FLASH registry is what I'm presenting here today. This is the largest prospective interventional device therapy in pulmonary embolism, and it's using the FlowTriever system. This is a large bore mechanical thrombectomy system. For those of you not familiar with it, it does have several parts, but the idea here being that there's a catheter that's placed either through the jugular or the femoral vein into the pulmonary artery, and using between 16 and 24 French catheters, are able to aspirate large volume clot this way. You can see a diagram here illustrating the catheter into the pulmonary artery. And partway through the study, the one thing that was introduced is called the FlowSaver device. It's a device at the bottom where we're able to actually filter the blood and reintroduce it to minimize blood loss during the procedure. The FLASH registry was designed as a prospective, multi-center, single-arm study with 800 patients with acute, intermediate, or high-risk pulmonary embolism. The objective of this study was to evaluate the safety and effectiveness of the FlowTriever system for treatment of pulmonary embolism in all-comer patient population. It was really meant to be a real-world study as a follow-up to the initial IDE study. The primary outcome was a composite major adverse event of device-related mortality within 48 hours, major bleeding within 48 hours, and any intraprocedural device-related adverse events. In addition, there was a 6-month assessment that included RV size and function by echocardiography, dyspnea score, 6-minute walk distance, as well as the PE-specific quality of life questionnaire that we'll talk through. Here's the flow diagram of the enrollment of patients during the 6 months. So 800 patients were enrolled at 50 U.S. clinical sites between December of 2018 and December of 2021. And we'll point out that right in the middle of the study is when the pandemic occurred, which did provide some challenges for some of these functional follow-up based measurements. Nonetheless, 799 patients were enrolled in the study. There was one that was enrolled and later found to have to be excluded. And 599 actually completed the 6-month follow-up, which I think, given the time frame and the circumstances, is a pretty good follow-up number of patients. The baseline characteristics and the acute outcomes have all been presented and published previously, so I'll just spend a couple of minutes and we'll quickly run through these, but I really want to focus more on the long-term outcomes of these patients. Baseline characteristics, the average age was 61 years of age. It was actually fairly evenly split between men and women. A few points to make: that 65% of these patients had a concomitant DVT. 12% of these patients actually had PA pressures greater than 70 during their index right heart catheterization. And 32% of these patients had a contraindication to thrombolytics. 8% were considered high-risk PE patients, and 76% were actually intermediate high risk. So over 80% of these patients were truly intermediate high risk or high risk PE patients. Again, the acute safety and procedural outcomes have all been presented and published before. But overall, as a quick review, 1.8% major adverse events at 48 hours, no deaths or injuries related to the device itself, and that there was clear improvement in hemodynamics on the table and during their hospital stay with reductions in PA pressure and improvement in cardiac index. So if we start now looking at the 6-month data, we can see here that the all-cause mortality from their index hospitalization through study exit at 6 months was 4.6%. Patients with serious adverse events through study exit was 13%. The 30-day readmission rate related to the PE was 1.4%. Prevalence of CTEPH, which is chronic thromboembolic pulmonary hypertension, was 1%. And the prevalence of what's now being termed post-PE syndrome or chronic thromboembolic disease without pulmonary hypertension was 1.9%. When we look at RV function as defined by echocardiography, we see that at baseline, the mean RV to LV ratio was 1.2, consistent with the patient population of intermediate high risk and massive PE. And that over time, at 48 hours, then 30 days, and finally at 6 months, there was a significant improvement in the RV to LV ratio. In addition, if we look at RV systolic pressure at baseline, the average was 48.8. And again, at 48 hours, 30 days, and 6 months, saw a stepwise improvement in this at 30 days that then leveled out and continued out to 6 months. Looking at a few other markers of RV function, here being RV systolic function on echocardiography. At baseline, almost 30% of patients had severely reduced function, 37% had moderate reduced function, and about 18% had mildly reduced function. And we can see here over time that by 30 days and then out to 6 months that 95% of patients had return of normal RV function based on echocardiography. If we look at right ventricular size, we see a very similar trend where early on the majority of patients had anywhere from mild to severe RV dilatation. And post-procedure, we saw an improvement. And then by 30 days and 6 months, a continued improvement, whereas 88% by study completion had normal RV size. Perhaps more important to patients is not their RV size on echocardiography, but it's really how they feel. And are they able to return back to a functional life? And so we're going to run through a couple of different markers of patient-related outcomes. The first here being the Modified Medical Research Council dyspnea score. This is a score that ranges from 0 to 4. Lower is better. A score of 0 means you only get short of breath with vigorous exercise. A score of 4, on the other hand, means that you become short of breath with just getting dressed, or you're so short of breath that you can't leave the house. And you can see here at baseline, whereas 41% of the patients had significant dyspnea in the hospital with minimal activity. And that over time, by 30 days and then out to 6 months, we saw a significant improvement in their symptoms and in their functional capacity. If we look at 6-minute walk tests, obviously there was no 6-minute walk test done prior to intervention, but by 30 days and then out to 6 months, we see a significant improvement in their 6-minute walk distances out to 375 to almost 400 meters by 6 months. The number of patients that had their 6-minute walk test at 48 hours was relatively low. This was at the discretion of the treating physician. And I know there are a lot of physicians that are reluctant to put patients that soon after a pulmonary embolism to a 6-minute walk test or a submaximal level of exercise. So at 48 hours, it was optional whether to do the 6-minute walk test or not, which is why the numbers there are low. Here's the Borg dyspnea and fatigue scores, both pre and post 6-minute walk tests, that once again shows similar trend, that over time, by 30 days and 6 months, there were significant improvements in their dyspnea score as well as their fatigue score. The total PE, pulmonary embolism quality of life score was developed about 10 years ago, and it's really based off the standard form 36, short form 36 quality of life questionnaire, but really tailored to be a little more specific to PE patients. And here we see that there, again, the lower the number, the better the patients feel. And we can see by 30 days and then out to 6 months, a significant improvement, again, in their PE quality of life. The questionnaire is really designed to ask patients about how they feel with daily activities, how comfortable they are around the house. And so that's why there's really not a good baseline at index hospitalization with this. So in conclusion, the FlowTriever system demonstrated a favorable short and long-term safety profile, as well as low mortality rates. RV recovery was achieved within the first 30 days, which was then sustained out to 6 months. We saw multiple markers of symptom improvement. We saw multiple markers of functional improvement, again, that we saw by 30 days and that continued out to 6 months. And taken together, that large bore mechanical thrombectomy can offer not only acute but long-term benefits. And I would really like to raise awareness and sort of challenge the field in general. Patients, they want to survive their acute PE, but they also want to be able to return toward normal life afterwards. And if there's something that we can do at the index hospitalization that gives them that opportunity, that's something that we need to continue to study. And I think that future PE studies are really going to have to focus not only on acute outcomes, the acute RV to LV ratio improvement that can be seen, but really focus on how we can help a patient feel better long term. I'd like to acknowledge and thank all of the other investigators through a variety of sites. And would also like to point out that this presentation will be simultaneously published in SCAI, I believe later today. So thank you very much.
Excellent. Thank you very much, Dr. Khandhar. We have about a minute and a half before we go on to the next late breaker. So I'll open up the podium for any panel comments or audience questions or comments, please.
I just had one quick question. You mentioned that you were searching for chronic disease. How focused should we be in looking for chronic pulmonary thromboembolism? You said that you had like a 2% number. Should we focus on that, or is that beyond our reach at this point?
I think we have to focus on that. I think we have to focus on not just having patients survive, but trying to do whatever we can to prevent chronic sequelae of their index PE. Absolutely.
Yeah, thanks for a nice presentation. Do you have any, I saw your serious adverse event data. Do you have any data on parsing the serious adverse events to procedural related versus non-procedural related AEs?
Yeah, the majority of the serious adverse events going out to 6 months, the most common ones were actually recurrent VTE, so having another DVT or a PE event, so unrelated to the procedure itself. And the third one being bleeding. So I presume that's related to being on anticoagulation for that period of time. There were no SAEs that were specifically felt to be definitively related to the device or the index procedure.
Okay. Good to know. Thanks.
Yeah, congratulations again. So just, are you following these patients long term?
6 months is the end of the follow-up, yes.
Because is 6 months long enough for CTEF?
Yeah, that's a great question.
And then, especially in the patients who are going to have recurrent events. And 6 months usually the time where if it's a reversible cause, you take them off of anticoagulation. So it'd be nice to have at least 6 months more of data on this to see. But excellent. I think this is the first time we've seen quality of life metrics improve after an thrombectomy. So congratulations.
No, thank you. I think your point is well taken. This is, we think of it as a PE as one event, but in a lot of folks, maybe a lifelong disease.